If you're going to take out a lens of a camera, you get the chance to completely rebuild the vision from scratch. No matter what you saw before, the choice you make is going to fully determine what they see, how they see, and how their quality of life will be. If it's not a good match, it can be very frustrating. So there's this misconception that the lens we implant inside the eye can actually focus back and forth. Unfortunately, at this stage, there's just nothing quite as good as what you're built with.
So, Gary, one of the things that I feel like is sometimes hard for patients to conceptualize is they think that the cataract is just a cloudy film and that how they saw before surgery is going to predict how they'll see after surgery. How do you explain that to patients?
Well, as Netta explained earlier, our eye is kind of like a camera. And so if you're going to take out a lens of a camera, you get the chance to completely rebuild the vision from scratch. And so no matter what you saw before, the choice you make or choice a patient makes for their lens implant is going to fully determine what they see, how they see, and how their quality of life will be, which we know if it's not a good match, it can be very frustrating. So that's why it's important before surgery that we have the conversation about what visual priorities are, and that a patient really takes an inventory of would they like a change. Not everyone likes change. Some people like to stick with what they have. So generally, I would say most patients do choose to have distance vision as a target for correction after surgery. And so if someone has been used to seeing in the distance and wearing reading glasses or bifocals or trifocals, it really does make sense for us to, give them the best we can with distance vision correction. And then if it's a monofocal lens, allowing them to use glasses for those other ranges. But as I mentioned before, not to belabor the point, we do have a lot of patients who are nearsighted, and they come in, and this idea of being able to see in the distance seems like an additive feature. But if they've taken their glasses off to read their whole life, that's a habit that's formed. It's sort of the way they've oriented their life around, taking their glasses off to read. And so if we do target distance vision, for example, and we're resetting the camera, if you will, patients can find it very disorienting to now have to put their glasses on to see up close. And so one analogy I use is that, if you've been right-handed your whole life or left-handed, and at 60, 65, 70, we say, hey, would you like to switch to the other side? You can do it, and there's no right or wrong. We're not here to tell you, what you need to choose, but it's just a choice you have to really think through and figure out, do I want to reorient myself for a different visual priority? Or do I want to keep what I have? And there's no right or wrong answer. It's an individual decision. But I think sometimes we make the mistake of rushing through that conversation sometimes and just assuming that people want to see in the distance if they're getting a monofocal lens. And I think it's more nuanced than that. And I do have a fair amount of patients. I would say probably 10% of my practice where I will leave someone nearsighted because we have the conversation about it and they are comfortable with near vision. And I have found that that's an okay thing to choose for patients.
And a lot of times patients don't realize that they do that. How many times have we had patients who come in and we ask that question? Do you use glasses to read? Do you, leave your glasses on if you're nearsighted to read? And they say, yes, I read through my progressives or bifocals. And then you hand something to that patient and to read, and they put their glasses on their forehead. So like you said, not to rush through this conversation and really highlight to the patient how they use their eyes, because we don't think about how we use our eyes, much the same way that we don't think about how we use our hands when we're writing, right? But the other, I think, complicated situation or conversation are patients who have astigmatism. So a patient who has had astigmatism and they know about astigmatism in their glasses and contact lenses, the conversation is easier with that patient because we then talk about correcting astigmatism with the lens implant, much the same way that they've had it corrected with their glasses or contact lenses. But there are patients who have astigmatism in their cornea, but their natural lens also kind of cancels out that astigmatism in the cornea. And when we remove the cataract, which is essentially the natural lens that has developed clouding, well, that canceling effect is gone. And now you have to correct it with a lens implant that corrects astigmatism. How do you have that conversation with the patient?
Yeah, I think that's a really challenging situation because sometimes I think patients feel maybe pressured by a surgeon to get the quote premium option or the advanced lens option when they're like, wait, but I don't need glasses now. So why are you telling me I'm going to have to pay several $1,000s potentially to be able to see like I see now? Can't you just take out the cataract, remove the cloudiness so I can just continue to see distance without glasses? I think that's a really important situation. And so for patients, if your surgeon is telling you, that they measure astigmatism on your cornea and they recommend a lens to correct the astigmatism, they're truly recommending what is best for you to maintain that ability to see distance without glasses. Similarly, I think there's some people who are really lucky that they've made it to cataract age and they don't need glasses for distance or for near, which is a minority of people, but they do exist out there. And for those people, it's really unpredictable whether just using a basic lens or a lens that's covered by insurance is going to give them the same freedom from glasses that they have. In general, they're not going to have that same freedom from glasses. And to be able to retain that ability to see far and near without glasses, they're really going to need the top tier of a multifocal, trifocal lens that's going to give them a full range of vision. So I think for anybody who's listening, just know that if your surgeon is making that recommendation and you trust your surgeon, it is truly in your best interest to follow their guidance and their recommendation. You have
Yeah.
something to
I think that's a great summary. I'll also say that there's this misconception, that the lens we implant inside the eye can actually focus back and forth, and it just unfortunately at this stage there's a lot of technology that's coming, and hopefully at some point we will have a lens that is similar to how the natural lens of the eye functions. But that's why there's trade-offs right now, is we just don't have a lens that's exactly like the lens that we're built with and we're born with. And so when we talk about trade-offs and range of vision, that's what we're talking about, and that's why we have to have that conversation. There's just nothing quite as good as what you're built with.